today to join us for our webinar on community-based health systems using housing as a platform. And I particularly want to thank the Kresge Foundation for funding the Health and Housing Funders Forum, especially David Fukazawa for his great leadership over the past 7 years funding the forum. Big thanks to our co-sponsors, grant makers in health and the Funders Network, especially Christina Gray and Danielle O'Hara, who both serve on the Health and Housing Funders Forum Steering Committee. I am Nancy Rockett Eldridge, Executive Director of the National Center for Healthy Housing, where it is my great pleasure to staff the Funders Forum. I'm very pleased today to have my friends and colleagues, Abigail Crocker, Howard Klink, and Amanda Saul agreeing to share their expertise with you today. As you can see from the screen, Abby is a research assistant professor at the University of Vermont Department of Mathematics and Statistics. Howard is the project director for Housing with Services Limited Liability Corporation in Portland, Oregon, and principal of the Klink Consulting Group. And Amanda is the Pacific Northwest Senior Program Director for the Great Enterprise Community Partners, a fabulous national organization. Today we're going to describe two successful systems change models, one in Vermont and one in Portland, Oregon. These models actually grew up together. We shared lessons learned, we benefited from each other's thinking. They really are sort of cousin models. You'll hear about why the models were developed and their impressive measurable outcomes. Throughout the 4 presentations, if you have a question or comment, feel free at any time to type the question in. We're going to save conversation to the last half hour of the webinar. So at that point, if you would like to state a question or comment, just raise your hand electronically and we will unmute you so that you can speak. And during that last half hour, we really want to get into a discussion about how funders have supported these models and opportunities for you to become involved in building these kinds of models in your own communities, as well as learning more about them. So at the end of the session, just raise your hand or type in a question. So I'm going to kick it off with a description of the SASH model created by Cathedral Square, which is a Vermont housing nonprofit with strong expertise in both Medicaid and Medicare. SASH is a housing-based service model designed to create a community-based system of care that is scalable statewide and was specifically designed to be replicable in any state in this country. It is an integral part of Vermont's healthcare reform system, attached to primary care medical practices as extenders into the home. It was originally funded through a CMS Medicare demonstration and is currently embedded in Vermont's all-payer model proposal to CMS, which is a very exciting all-in waiver that is under consideration by CMS. And if it is adopted, then SASH will be an embedded part of that waiver, and it will be allowed to expand to more individuals in the state. So the reasons we created SASH are important, and I want to start with that. So first, just the sheer number of baby boomers really demands a true system of care, and we don't have one in this country. The baby boomers have driven systems change in every phase of their lives. These kids on the screen, they were born in the 1950s, in the middle of the boom. This was the population that drove our federal government to create true public health, public education systems, uniform standards around education, permanent funding. This significant demographic has driven systems change at every phase of their lives until now. Just when boomers are starting to need a true system of care, there is no national system that integrates health and social service needs for seniors. if we have any policy today, it is that we impoverish seniors and people with disabilities, they spend down to Medicaid, and then we institutionalize them. We must create a better system of care driven by consumer needs. Second reason we created SASH was that as important as nursing homes are and assisted living residences, most people just want to stay in their home. Even if everyone was clamoring to get to a nursing home, in most states there are just not enough beds that are affordable. We aren't producing enough affordable housing either, so the waiting lists just keep getting longer. And fortunately, federal and state fair housing laws protect seniors from eviction or any pressure to move out on the basis of health status, physical or mental health status. This is a very good thing, but it means that where seniors live today is where we must be prepared to provide the services that they will need, even at very high levels of care, including nursing home level of care. We must bring services to them and not expect that they can or should move to get the care they need. Third reason we created SASH was, while you can see on the graph on the left that this is a chart that looks at the determinants of premature death. And it shows that only 10% of those determinants relate to traditional health care. 50% relate to healthy behaviors. Yet, on the right-hand side of the screen, you can see that only 4% of our national health expenditures really support prevention. We must invest more in prevention. And the good news is that it's easier to promote healthy behaviors at home. This kid says it all. He eats his fries at home. He doesn't eat them at the doctor's office. That is where the vast majority of seniors will age, in their homes. So for seniors who spend the majority of the day at home, housing is the best setting to establish and support healthy behaviors. Next, as all of us in the housing world understand, the needs of residents in HUD-assisted or RD housing or tax credit housing or public housing are very high. But fortunately, in March of 2014, the Lewin Group and Leading Age came out with a report that absolutely confirmed what our perception was, that residents in HUD-assisted housing are the highest need, highest spenders, most frequent users. And so building on this support system, starting at federally assisted housing, just makes a whole lot of sense. And importantly, this is where health disparities show up in the country's poorest neighborhoods, poorest buildings. So given consumer preferences, we know we have to move away from a system of care that has been highly centralized and highly institutional to a very decentralized system. Just like the public education system that I talked about before, where schools were in every neighborhood, very decentralized. Back in the day, we had to build those schools from scratch. Now we're in a much better position because today we've already got an existing, ready-made, decentralized network to place our health services, and that is in the built federally assisted housing. It's a perfect match and perfect platform for decentralized senior care. And, of course, these are the places that happen to be the homes of the poorest minorities and people suffering from health disparities. We should just use the platform that's already available to us. So, knowing that building the senior support systems on top of housing made all the sense in the world, Cathedral looked at how the system could utilize existing resources and integrate fully with healthcare reform. So at the time we were designing the program, this was back in 2010, Vermont was very focused on chronic conditions, prevention, how to increase access to Cathedral Square, to primary care, sorry. So Cathedral went to the state government and said, hey, let's partner up because primary care providers want to support patients with chronic conditions, and we actually know who they are and where they live. We also did not want to duplicate the huge expertise at the area agencies on aging, the home health agencies, the designated mental health agencies. So we worked with them to form care teams that support groups as a team, supporting 100 SASH participants. That required a lot of team building, takes a lot of time, a lot of training. SASH has a rigorous and continuous training curriculum that builds skills from dementia care to how to be a good teammate. And of course, everyone is looking for ways to reduce hospital admissions, ER use, readmissions. And so as you can see in the puzzle piece there, every hospital in the state signed up to be part of this systems change. All of them committed to working with us on both admissions and the discharge process for SASH participants. And some hospitals actually said they were going to start flagging SASH participants in their own databases. So when someone came in the ER, they knew exactly they had SASH support. So for over 5 years, SASH has been working as an extender to community health teams and primary care offices. Medicare initially provided $10.3 million to enroll up to 5,400 Medicare beneficiaries. And in addition to that, the Vermont Medicaid program has been contributing about $1 million every year. So what happens when a person enrolls in SASH? Well, first, it's voluntary, very voluntary. This is all about person-driven decisions. But once they do enroll, they get a annual or more frequent if needed detailed assessment that it not only includes ADLs and IADLs, but also nutrition screens, depression screens. We do a mini COG validated screen. There's a shared care plan that's developed with the person. So the person is in the driver's seat. The person is told what the assessment showed and then asked, what do you want to work on? And often that includes the family as well. All the personal health data is put into the state central clinical registry, which is now being converted over to one of our accountable care organizations. Residents' health is looked at both from an individual perspective but also from a population perspective so that we can use our vast directory of evidence-based practices to pick what does the data show that we ought to be using, which evidence-based practices are needed in which community to address some of the peaking issues that are reflected in data. And then we are always partnering with the Department of Health on their Healthy Vermonter 2020 goals. In fact, I've had some fantastic work with the Health Department and the CDC on tobacco cessation and on addressing hypertension and uncontrolled blood pressures for our participants. And this has led to some really cool programming like our Teletai Chi program that exists in the central part of the state. So SASH is all about systems change. We are not a program. We're not like you can do PACE or SASH. This is about a system within which any program can fit. And so key points here is that we want to make sure that we are, number one, not just dealing with the sickest people in the population, but dealing with everyone from the healthiest to the more frail. We are also reliant very much on the global budget that we receive through Medicare. Essentially, they pay a capitated per person payment that bundles up into one flexible pool of funds to employ a care manager as well as a wellness nurse. And importantly, one of the things that CMS insisted upon that we were so pleased with is that we insisted any Medicare beneficiary be eligible for this. So we were not to limit it to people who lived in low-income housing or to people who were sicker than others. They really wanted to make sure that as Medicare beneficiaries, you had access to SASH wherever you lived, whatever your health condition. That's key to the program. And then another key point is that we want to provide a continuous source of trusted support. So although a participant can disenroll at any time, very few do, but you certainly can, but we don't discharge anyone. We never say, okay, you're done, you're fixed, you can no longer participate in this. Because it is a system, and we think that a reliable safety net is essential to managing chronic conditions. So you're looking at a map of the state of Vermont from the Canadian border on the north to Massachusetts on the south. Our goal from the outset, as I said, was to get to scale, was for every corner of the state, every county to have SASH in it. We had seen one too many boutique projects where a few elderly get this awesome residential setting with services and everyone else got nothing. So it was really important for us to build a cost-efficient model, one that could be applied to Medicaid, Medicare, and commercial insurers. So in order to do that, we felt we needed to organize the state from the start. So we organized all 21 in our state. We have 21 nonprofit housing organizations. That includes public housing, NeighborWorks organizations, enterprise-funded projects, every housing organization. And then we divided the state up into 6 parts for political and funding and operational reasons. So what's next with SASH? Abby's going to talk about the results, awesome results we've had. But at this point, now that we've built a really strong foundation statewide, we want to build on top of it. And a couple of ways we want to do that, particularly telehealth. We want every senior who wishes to remain in their apartment and visit their physician real-time, virtually, that they can do that. That we don't need to be dragging people out in the middle of a snowstorm, as you can see right there. That poor woman dragged out on the bench without a coat. We don't want that person to have to go through a storm to see their doctor when the technology is so sophisticated these days that in many, many cases, we don't need to be diagnosing the flu by dragging somebody to an emergency room and sit there and catch everything else. So that is a really important direction. We got Medicaid to agree to fund primary care visits via telehealth as long as they're not duplicative of an in-person visit. We want to keep adding new interventions as they become evidence-based and proven. We want to build our workforce, particularly build our community health workforce. We feel that too many functions in the healthcare world are still required of physicians and highly trained nurses when some of those functions can be pushed down to very capable community health workers. And most of all, we really want to get to bringing this model and other models like Howard's to scale nationally so that every state in this country has these models. A very good start to this is HUD's supportive services demo. We just received word that the contract for implementing the 3-year, $15 million demonstration to bring supportive services like SASH to 40 HUD communities around the country, likely in 8 to 12 states or so. That contract was just awarded to the Lewin Group and my center and Leading Age are subcontractors to that. So very exciting that we'll be doing that work and starting to get this stuff to scale. So again, back to systems change. What we are really looking for here is a move from an approach to care which is always episodic to a continual team support approach. We're looking to focus on both population health and person-driven individual needs, both at the same time. We want to make sure that this new system brings the care to home wherever a person calls home. We want to be sure that services are brought to seniors and not require that, as we have for decades, require that people actually move to get the care they need, and that it be both cost efficient and better care, and build a system that really begins not with payment reform, but begins with what do people need. So I want to thank CMS, HUD, State of Vermont, the Cathedral team, the foundations that invested in us from the get-go for making SASH a proven national model. And now it is my absolute pleasure to introduce Dr. Abigail Crocker. Abby has the rare skill of being able to analyze complex data and methodologies used and translate them into English for all the rest of us. So welcome, Abby.
Thank you, Nancy. I just want to start off by saying how grateful I am to be here today. I love talking about the SASH program. I think it's a great program, and I think you're starting to understand that too from hearing what Nancy said and has talked about it. SASH team is got a great group of dedicated individuals, and I really appreciate how much they value the measurement and measuring the impact of the SASH program. And so that's what I'm here to talk about today. Is the model sounds great, but is it working? And how are we measuring to make sure that it's working? So really I want to focus on two big questions. We know the program sounds great and it makes sense, but does the model actually benefit health outcomes? And benefiting health outcomes is great, but if it's really expensive and it costing us a lot of money, then it's not going to be sustainable. So are we not only improving health outcomes, but are we also controlling costs or maybe even saving money? So these are our big things we want to focus on in terms of an evaluation. So let's start for this first one. Let's look at health outcomes. To start off here, let's think about who the SASH participants are. Nancy talked about how SASH is throughout the entire state of Vermont, but really that means about 5,000 people. So at any given time, the SASH program is supporting 5,000 individuals. We've probably had closer to 7,000 or 7,500 people who've passed through the program, but the active cohort is about 5,000. The average age of the individuals there is 72. As Nancy alluded to, folks who are living in these types of housing situations, tend to have different needs than sort of quote unquote the general population. So we wanted to look at this a little further. So we looked at the state's all-payer healthcare claims database to compare the SASH population, the SASH Medicare population, to the non-SASH Medicare population in Vermont, looking at these different conditions down here. And what you can see, all the red bars are a little bigger than all the blue bars, meaning that the SASH folks tend to have sort of higher rates of all of these different conditions. So across the board, higher rates of diabetes, higher rates of heart disease, pulmonary disease, heart failure, depression, etc. So we're starting to see higher rates of that. Also, when you look at these conditions another way, are sort of the SASH population tends to be sicker in terms of the clinical risk groupers. And clinical risk groupers is an algorithm that you can apply to healthcare claims to sort of classify people as healthy up through a scale of having multiple catastrophic conditions. And what you'll see here on the left is the distribution of those health statuses, those clinical risk groupers, for the non-SASH Medicare population in Vermont. And then on the right, you've got the SASH Medicare population. And what I want to draw your attention to is this blue chunk at the bottom. That blue chunk at the bottom represents the proportion of participants who are considered in the healthy classification. And you can see that blue chunk is a little smaller for SASH compared to the non-SASH folks. Likewise, this orange chunk right here, which is the multiple comorbidities, so multiple chronic comorbidities. It's bigger in the SASH population versus the non-SASH population. So we've got about 5,000 elderly folks living in SASH panels throughout the state of Vermont who tend to start off being a little bit sicker, having a little bit more higher needs than the rest of the population. So how does this translate into what impact SASH can have on health outcomes? Well, SASH, as Nancy mentioned, we have this great centralized database, and it's great because it's got a ton of information in it, and we really track health outcomes for every individual participant. And so I'm going to show you 4 selected measures from that database. It's these 4 because there's just a lot right now, and it's hard to always focus on which ones we should be focusing on. So these are 4 that tend to make sense to us. The first is the documented advance directive. So let's look at that. So having a documented advance directive, well, that makes sense because it really helps figure out what you want to do sort of at the end of life if something happens to you sort of mentally. It's really great for planning, and everybody is encouraged to have a documented advance directive. Unfortunately, the rates are pretty low, so the U.S. benchmark right now is about 26% actually have documented advance directives. In the SASH program, that number is almost 60%. So by actually putting these folks in housing organizations where we can work with them, we're actually able to see we can have a huge impact on making sure everyone has an advance directive. And this is something that we focus as a continuous quality improvement strategy. So we actually want this, closer to 100%, but we're getting there. Another health outcome measure is a shingles immunization. So shingles immunizations, shingles prevention is important for everybody, and in particular in the elderly. And unfortunately, not a lot of people actually get the vaccine. It's something you just basically need once, but actually as few as 10% of folks actually have the shingles immunization. In the SASH program, we've gotten this number up to about 34%, so statistically significantly better than what you would see in a general population. Again, likely because it's the housing-based program. Coincidentally, there's other immunizations where we see similar patterns. The seasonal flu, we have high rates of immunizing folks against the seasonal flu, and the pneumococcal vaccine as well. So being able to host these immunization clinics really provides access to care that the general population isn't necessarily getting. Another one that people are usually really interested in is falls. So falls in the elderly is a huge health concern. And there's a lot of interest in preventing falls or minimizing falls in the elderly while promoting a strong quality of life. So the falls rate in the United States for folks in the 70-plus age group who've had at least one fall in the past 12 months is about 35%. So about 35% of people 70 and older have fallen at least once in the past 12 months. So here we really want to see the SASH rate to be lower than this, and that's exactly what we do see. Is we can't eliminate falls completely, or we haven't found a way to do that yet, but we definitely minimize the falls and improve strength, and this is all through sort of evidence-based falls prevention programs that are implemented throughout the entire state, and we're starting to see those efforts really pay off. Finally, the fourth measure that I want to talk about for health outcomes is hypertension. So controlling hypertension is really important. So folks who have high blood pressure, we want to be able to implement methods to keep that blood pressure below 140/90. And the rate of controlled hypertension, so the people who have blood pressure less than 140/90 that have a diagnosis of hypertension is pretty low in the United States. So in general, it's about 30%. So about 30% of people in the U.S. who have hypertension actually have that controlled. So through lots of great efforts with a great hypertension management team in SASH, we've been able to increase this to 77%. So this is a huge amount of potential, and this is through targeted interventions and a focused hypertension management program. I'm using the SASH staff sort of in the field working directly with SASH participants on a daily, a weekly, a monthly basis. And so we've seen this huge rate increase that was well above what we would compare to the general population. So it looks like we're doing pretty good for health outcomes. So watching these health outcomes, we've seen a lot of success. And so it then leads us to that next question of how about costs? So we're seeing health outcomes at some measurable health outcome improvements, but is it at an expense? And so when we want to actually look at costs, the SASH team themselves doesn't have the cost data. And so what happened was the Leading Age and RTI International did a third-party evaluation. So they went in and actually looked at the cost analysis, and the link to this full report is right here. This is great because it was extremely rigorous. Like, you can't get much better than this. It was objective. It was, from somebody on the outside looking in. They used Medicare data to actually look at utilization and expenditures. One of the best things that I personally loved about the analysis was that they had SASH Medicare data, and they compared it to a comparison group that was, I thought, a really great comparison group. Other Vermont-based affordable housing participants who aren't part of SASH. So sort of comparing like to like, with the difference being one group was in SASH and the other group wasn't. So when the first annual report came out, so this was the first findings from this Medicare utilization and cost analysis, you know, you sort of hold your breath, like, oh, is it going to actually show cost reductions? And after 1 year of implementation with a sample size of 549, so it's 549 SASH participants compared to some controls, they found, yeah, it actually did. It was doing a great job in reducing costs. The average annual growth was reduced by approximately $1,750 and $1,756 per beneficiary. So right off the bat, we started seeing some significant findings in terms of its ability to reduce Medicare expenditure. Then we said, well, okay, that's great, really promising initial results. But when we look again 2 years later, tripling the sample size, and after SASH has been in effect for 3 years, are we still seeing the same thing, or, you know, are we going to start to see something different? And based on the third-party evaluation, it was really reassuring, because we continued to see this. We continued to see that SASH was not only improving health outcomes, but it's working to slow the growth of annual Medicare expenditures. And we got an estimate of about $1,536 per beneficiary in this analysis, which, again, great finding, and is in about the range of the $1,756 per beneficiary that we saw in the initial analysis. So far, so good in terms of reducing costs and improving health outcomes. So where do we go from here? So when we talk about what's actually happening on the ground in the SASH program and the desire to reproduce it and the potential to reproduce this great program, right away we need to focus on establishing a bidirectional health outcomes database system. We talked about how important the centralized data system is for informing not only individual health management, but population health management as well. And we believe that this will be even more powerful if we're able to actually put the data in the hands of each panel coordinator using a highly secure bidirectional system. So right now they can give the data to us, we can analyze it and then give them reports like once a month or so, but we want them to be able to see it real time and manage individuals and their panels at the same time. Where we really want to go with that, so once we establish that data system for driving SASH in Vermont, we see it as a huge potential to act as a data hub and a shared data system for other organizations who want to replicate SASH-like programs in the entire country. We've put a ton of effort into making sure we have standardized, validated measures that matter, and they're collected in a way that we can use them in a meaningful manner, both with an individual patient as well as populations, and for driving, where do we go with the next evidence-based practice? And so we think it would be a great opportunity to leverage all of that work and leverage the single data resource to support lots of organizations. And then sort of the really exciting next step would be to expand that data set to include Medicare claims ourselves or other data sets. Just sticking with health outcomes alone is great and can do a lot of things, but if we could expand to other data sets, sort of the sky's the limit. I would love to see us be able to do our own Medicare claims analyses to look at subgroups, different factors that might be more predictive of success earlier, just so we can learn what to do. And if we do start to see things go off track, we can intervene quickly. So the potential of a data system like this is really big and exciting based on the groundwork that we've seen from the success of SASH. So thank you very much. Again, thank you for the opportunity to talk today. I love talking about SASH. If anybody has any questions about anything I've said or comments, please don't hesitate to reach out. My contact information is there. And at this point, what I'd love to do is turn the screen over to Howard Klink, who will talk about the program in Portland, Oregon.
this up and running. So I was about to say good morning, but I guess it's afternoon, at least on the East Coast and in other parts of the country. I want to thank Nancy Eldridge and the sponsors of the seminar, of the webinar. I'm going to give you some information today about the Housing with Services project in Portland, Oregon, which is in the third year of a 3-year pilot. I'm going to get fairly detailed about the services delivery model that we're using and the administrative structure we've set up. I will say from the outset that part of our funding has supported a 3-year evaluation that's been conducted by Portland State University, Dr. Paula Carter, and we're just this month, crunching the final numbers, putting the final report together, and can give you some general indicators, but I don't have very specific information, but will soon, about the evaluation of the project. And the evaluation data, I will say, looks really, really good. I know from the profiles of the people that are part of the organizations that are participating in this webinar that you don't really need to see a definition of social determinants of health and health equity. I have included them in this PowerPoint presentation just as a reminder that this project started. It grew from a planning process that identified housing as a critical social determinant of health, and looked at the framework for developing the program and the services delivery model through a health equity lens. We used social determinants of health definition and the health equity definition as accountability tools. Every time we refine, develop, add a program element, we look at the values framework that's defined in social determinants of health and health equity as a basis for saying, are we still connected to our original mission? Are we focused on the priorities that we need to be focused on? Are we addressing the groups within the large category of seniors and people with disabilities that have very culturally specific needs and specific barriers and challenges? For those of you that are remember the original definition from Healthy People 2020, you'll notice that I have updated, took the liberty of updating this definition to include some other specific, culturally specific groups. So it's that's the reference to mostly in the definition. Let's do the numbers, as they say in NPR's Marketplace, to give you a basic overview of the project. Housing with Services includes 11 Section 8 and rent subsidy apartment site housing 1,408 seniors and people with disabilities. The overwhelming majority of people in these 11 buildings are over 65. I think the average age is 66. We do have a couple of handfuls of younger people with disabilities, but it's nearly exclusively a seniors and seniors with disabilities population. We have 9 limited liability corporation partners, and I'm going to talk a little bit more about that throughout the slideshow, including 3 housing agencies, the state's largest Medicaid insurer, which is Care Oregon, and 5 social services nonprofits. I will say now that when we set the project up early on, we considered a variety of administrative structures to launch it, including 501c3. The LLC model was chosen as an efficient model to manage the project, and we also required equity share contributions, which gave us, which resulted in the partners that participate in the project having both skin in the game and gave us some working capital to launch the project. We have a LLC operating agreement that requires equity contributions. I just mentioned that defines decision-making and risk-sharing, among many other elements of how the partnership will work. The LLC staff which is 1 full-time operations director and a part-time project director, which is me, provide administrative support and services coordination management. And then services are provided by staff assigned to Housing with Services and funded by partner agencies. And I want people to remember that last bullet because one model is to have agencies that provide healthcare services, accountable care organizations, hospital systems, and insurers contract with us to provide those services. That is not the model that we've chosen. We have a very cost-efficient care coordination model, and the hospital systems and insurance companies, and in one case an accountable care organization, pay for staff that are assigned to our project, and we coordinate the services that are provided. Okay, I just lost there we go. Housing with Services initial funding sources. Enterprise Community Partners has been a significant partner from the very beginning of the project, provided us funding from the very onset to seed the development and throughout the life of the project. We got an initial grant from CMS as part of Affordable Care Act funding that came to the state, which funded both the planning, the launch, initial implementation, and the Portland State University evaluation that I mentioned earlier. We got funding to construct a health and wellness activity center, and which will also house a primary care clinic in one of the 11 buildings, and then the reference to the Housing with Services partner equity contributions gave us the $335,000 of equity share contributions that gave us working capital also to launch the projects. This is important, additional funding sources. We had funding primarily through the Affordable Care Act, the State Innovations Model Grant that came to the state that funded us for 2 years. We've since been very successful at raising funding from local foundations and community benefits programs, Meyer Memorial Trust, Providence Health Systems. Family Care is one of the 2 accountable care organizations in the Portland metro region that's given us a generous grant. We recently, in the 3rd year, got a grant from Enterprise, and recently acquired a grant from NeighborWorks to fund the project. So this funding has extended the life of the project through year 3, possibly into year 4, and we're in the process right now of discussions with current partners and partners that have not yet funded us for long-term sustainable funding based on the evaluation data that's going to be released next month. Housing with Services goals, these were in place at the beginning and have been metrics that are being measured by the evaluation: improved health outcomes, reduced healthcare costs, delayed entry or re-entry into institutional care, increased resident and community engagement, sustainability through healthcare stakeholder support. That's the brass ring that we're going to be working on through the end of this year and into the beginning of next year. Increased resident access to mental health, addiction, and culturally specific services. Let's jump and talk about the services delivery model. This is kind of the primary substance of the presentation that I want to focus on. Of all the 11 buildings that we have, again, 3 different housing agencies. We have resident services coordinators, either part-time or full-time, assigned to each of the buildings. And it kind of depends upon the housing agency's ability to financially support. Some buildings have full-time resident services coordinators that are employees of the housing agency. Some have part-time resident services coordinators that are assigned to multiple buildings. We have health navigators, which are registered nurses supported by Care Oregon, which is the region and the state's largest Medicaid insurer. They're assigned to the project full-time. We have 2 of those, and they're doing information and referral, light touch nursing, behavioral health support and intervention, facilitating access to primary care, and a whole range of other activities on the ground in the buildings every week. We have a health and wellness activity center, which we use for resident engagement activities. We just, within the last few months, contracted with a federally qualified health center who's setting up shop in our health and wellness center to bring in acupuncture, massage, and 2 geriatric specialist MDs to provide on-site primary care and same-day appointment urgency care for our building residents. We've got prescription medication management provided through a program, again, that's supported by Oregon, the Medicaid insurer. We have contracts in place with Islamic Social Services, Jewish Family and Child Services, Catholic Charities, and the Asian Health and Service Center for the roughly 30% of our total population, culturally specific groups, to do outreach and education and healthcare navigation support for those groups. We have site-based mental health and addiction services. We have a resident services exchange, which again is supported by Oregon. Food insecurity prevention and intervention. We're distributing about 6,000 pounds of food a week. High levels of food insecurity in all 11 buildings, and that's a resident and volunteer supported program. And then lastly, we have an interagency agreement among about 15 community-based nonprofits that were already providing services in the buildings. And we spent about 6 months putting together kind of a mission-driven collaboration agreement that identifies cross-agency referral protocols, information sharing agreements, and a commitment to participate in meetings and calls every couple of weeks to support care coordination for the individuals that are being served by the program. We have to really focus, Nancy picked up on this theme early in her presentation, consent to participate, release of information. This keeps us out of, it improves our ability to engage residents and keeps us out of HIPAA jail. Release of information, notice of privacy practices. We've established a resident bill of rights and grievance procedure. We have extensive policies and procedures about information sharing. And we have one of the best models for resident engagement that I've worked extensively in public health and disabilities space on resident engagement strategies. We have a really active resident advisory council that's been involved since before the project launched. They've helped us identify service priorities. They've helped us design the evaluation, survey instruments. They do outreach, education, provide services through a service exchange model. Very, very involved resident group. What's in it for the healthcare system? This is a little bit of an oversimplified summary, but access to research and evaluation data for serving complex, challenging populations for which the providers don't claim to know not a lot about at this stage. Improved individual and population health outcomes, which are evaluation data, is validating reduced healthcare costs. In Oregon, we have 33 metrics that the accountable care organizations are held accountable to, 17 of which have financial incentives and disincentives attached to them. So working with this priority population improves the ability of the accountable care organizations to comply or improve their records, at least with ACA imposed mandates. Some of the hospital systems have really high Medicare readmissions penalties, and to the extent that they have staff on the ground or a connection to our program, they can improve the record with respect to transitions in and out of hospitals and emergency departments. And then the hospitals and the CCOs are benefiting either through community benefits investment. They're getting good brand identity association with community investment and innovation and taking advantage of that. And I think that's my time. It's my pleasure to introduce Amanda Saul. Enterprise Community Partners in Oregon has seeded significant numbers, and you're going to hear about these in the evaluation, played a great support role with development of health and housing integration projects. Amanda's established a leadership role in the state as an expert on health and housing integration, and recently had significant impact on the Medicaid waiver policy revisions that were submitted to the state, and we're waiting to hear about the approval of those. So Amanda, on to you.
Thank you, Howard. Thank you all for listening and for participating. I'm going to quickly go through what we call the core study, or the Center for Outcomes Research and Education study that Enterprise partnered with to create this health and housing study. This study actually includes the Housing with Services project that Howard talks about, but it also includes a number of other projects that are owned by 8 other organizations, nonprofit organizations, and the Housing Authority in the Portland metro region. So real quickly, Enterprise is a national nonprofit organization that provides both financial support, policy support, and program solutions to housing organizations, and we've expanded our reach to think about housing as a platform and think about the connections between housing and health and housing and education and housing and transportation. So this is an effort, this study is in an effort to sort of make those connections between health and housing a little bit more clear. So what research questions we were trying to identify in this study is what's the effect of stable, affordable housing on healthcare outcomes in a low-income population, and specifically what role do integrated health services play in healthcare expenditures and quality. In the past, there's been a number of studies that have been done to look specifically at the impacts of healthcare costs for people living in permanent supportive housing. And we wanted to expand this research a little bit further and look at the impact of housing and health-related services associated with housing for people living in housing, specifically for seniors and people with disabilities, and people living in affordable family housing. So what's different about this study? Once again, we partnered with the Center for Outcomes Research and Education, and we're actually able to use claims data to assess healthcare costs and utilization. And then, as I was saying earlier, we looked at several different affordable housing types, family housing, housing for seniors and people with disabilities, and individuals living in permanent supportive housing. We specifically were focused on the effects of integrated health services. And the study started with an analysis of the impact of Medicaid services that covers more than 10,000 residents that live in affordable housing in the Multnomah County area. So just really quick to give you an idea of the people who live in our housing. I think it's important to understand this. So the gray bar on the left is the average Medicaid member who lives in Multnomah County, and then the blue bar is people who live in family housing, which includes children, and then the next green bar is people who live in permanent supportive housing, and lastly seniors and people with disabilities. And so as a housing person, I was really shocked, I guess, to see that how sick the people are that live in affordable housing, and for me it just made it even more important that we all do a better job linking health and housing, because the people who live in our housing really need it. And then once again, you see the same examples happening when we're looking at the prevalence of behavioral health diagnoses. So once again, people living in affordable housing are 2 and 3 times more likely to have behavioral health diagnoses, and this is based on Medicaid claims data. So what we did is we matched the people who lived in the housing to people who were actually on Medicaid, and then we looked at their move-in date. And we wanted to make sure that we were picking people that were on Medicaid for at least 3 years prior to moving into 3 months prior to moving into affordable housing, and 3 months after moving into affordable housing. And once we sifted through that, we were able to the Medicaid portion of the claim study includes 1,625 residents. One of our key findings is that the Medicaid per member per month costs went down by 12% on average for all of those people who lived in affordable housing. So just by moving into affordable housing, their Medicaid costs went down by $48 per member per month. And if you extrapolated that across all 1,600 residents, that's an annual cost reduction of nearly $1 million just by moving into affordable housing. And once again, you can see that those cost savings were true across all three target populations. And you'll actually see that the percentage increase was higher for the projects where people with seniors and people with disabilities live. And just to point out that this does not include Medicare costs. This is just Medicaid costs. So it's just those dual eligible elderly folks. The next key finding was that once people lived in affordable housing, they started to use healthcare in the right way. So their emergency department use went down by 20%, and their primary care use went up by 18%. And once again, you can see that that's true across all of the different target populations. It's especially true for people living in permanent supportive housing, but it's also true for seniors and people with disabilities. And then once again, across all three housing types, you can see that the primary care visits went up across all housing types, increased after moving into affordable housing. The next part of the study was a self-reported survey. We wanted to understand that people's costs weren't going down, not just because they weren't getting the care they needed. So we asked people about their ability to get care after moving into affordable housing. And across the board, all the survey respondents said that their ability to get care was the same or better after moving into affordable housing. And I will say, just thanks to those resident services coordinators in those affordable housing buildings, we were able to get over a 50% response rate to our survey. And once again, we asked people about whether or not their quality of care was the same or better. And once again, across the board, the target populations in the three different housing types said that their quality of care was the same or better. So lastly, we really wanted to be able to understand better the impact of integrated services. And we had hoped to be able to say, this specific service for this specific target population delivered the best health outcomes and reduced costs. Unfortunately, because the services varied so much across the 145 projects, it was really hard to target it that directly. But the researchers bucketed the staff and services into these three categories to assess their impact. And so we bucketed the services into health staff and services, which includes medical, mental, and dental staff and services. Sometimes these services are on site, but sometimes it's just a really close coordination with a provider. Next, there's social staff and services, which includes social workers, community health workers, and health navigators. And lastly, wellness staff and services, which includes food, as Howard was mentioning, food brought into the projects, or maybe cooking classes, fitness classes, and other residential activities. And so the researchers were able to determine that the impact of specifically the health staff and services helped to drive down the costs to an additional $115 per member per month. So that's saying that in comparison to just your average affordable housing project where there's going to be $48 per member per month savings, at projects that have integrated health services, those costs went down by $115 per member per month. And in addition, we saw that the emergency department visits were also decreased at those projects that had integrated health services. One of the other interesting things that we found is that in some projects, the awareness of the availability of services was low. And so, you know, this would be a really easy way to increase the impact that these services have, both on people's health outcomes and on Medicaid costs by increasing the awareness of the available services at each site. So really quickly, I'm going to talk about what's next, what's happening in Oregon. So it's really exciting that the core study came out at the right time, and in addition to that, we have a housing crisis in Oregon. There's more homeless people now than there have been ever, and there's just not enough affordable housing. And so I think it was the perfect storm that we were able to work with the Oregon Health Authority on its Medicaid 1115 waiver to include in the draft waiver to CMS that Medicaid funds will be used to provide housing supports for people on Medicaid. And so that includes things like homeless prevention, care coordination at exit from a jail or a hospital or a skilled nursing center, tenancy supports to help people get moved into housing with first and last month's rent, and then also housing sustaining services with eviction prevention and other services that could be needed. I think what's really important, lastly, is that in Oregon, the coordinated care organizations had access to flexible benefits funding, which could have been used to provide these supports in the past, but not many of the CCOs were using these flexible benefits funding because they were considered administration expenses, which affected their budget. And so the Oregon Health Authority is proposing that these flexible benefits funding be treated as health-related expenses, which sort of goes along with the whole ACA concept of providing greater health services outside of a traditional clinical setting. So we're waiting to hear more from the Oregon Health, or from CMS, about whether or not the waiver is approved. And in the meantime, the Oregon Health Authority is moving forward sort of with the hopes that it will be approved to sort of think through next steps of implementation and how a Medicaid insurer will provide these types of services going forward. So I think it's really exciting. So I'm going to hand it back over to Nancy now, who's going to open it up for a little bit more of a discussion. Thank you.
Great. Thank you, Amanda. That was thanks to Howard and Abby and Amanda for such detailed and clear presentations. I am going to try to, yes, there we go. So now I'd like to invite the audience to either raise your hand electronically, and Michelle here will unmute you so you can make a comment or ask a question. We do have one comment that we received during the presentation relating to HIPAA compliance, and I can just simply say that for the SASH initiative, we were very focused on HIPAA compliance. We have very detailed agreements, as Howard described as well, in Oregon, and do an enormous amount of training around HIPAA compliance consistently, because I think one of the challenges, concerns that our Accountable Care Organization and our Health Information Exchange had was whether housers knew how to follow the rules. And as I always say, you know, others are excellent at compliance. That's what we do. So so HIPAA compliance has not been an issue, but it has been very front of mind to protect the privacy of individuals.
I had a couple of things to that we've done with respect to HIPAA compliance. We have a local large law firm that in their DC office has two former CMS HIPAA compliance officers that are part of their health policy skill set, and we work with them on development of policies and procedures. One interesting thing they advised us about, you know, is that as an LLC, are we a covered entity, or did we need to be a business? Did we need to establish business associate agreements with our partners and provider agencies? And their conclusion and advice was that we're certainly not a covered entity because we're not providing services. Secondarily, we're not providing services on behalf of covered entities. So even though we've been able to escape some of the technical requirements of HIPAA compliance, we're doing it anyway. Not completely, but we've got a full set of policies and procedures, and we are using a software application developed by the Pangea Foundation based in the Bay Area, and it's called Family Metrics. That collects data, does reporting, is care coordination and communications software, and it's built to be HIPAA compliant and highly customizable. So we've taken steps down that road, but have gotten legal advice around the status of the LLC that's protected us from having to be to go through a very costly development a process of policies and procedures.
Great. Thank you, Howard. We have a question that has come in, and the question basically is the movement around both the homeless population and the affordable housing, need for affordable housing has in some places eclipsed the health and housing movement. And the question is, how are we positioning our work within those issues as they're being played out in the community? Panelists?
I can. This is Amanda. I can talk a little bit. I think because of the housing crisis, it's brought people together more. So for the first time, you know, our state housing finance agency, Oregon Housing and Community Services, is meeting regularly with the Oregon Health Authority, and they are doing joint RFPs, requests for proposals, and providing funding specifically for mental health housing. There's also in the Portland metro region, the cities of Portland, Gresham, and Multnomah County have come together to create a collaboration called A Home for Everyone that has specific goals around ending homelessness and has brought the healthcare community to that table, which is fairly new. And just this morning we were talking about using health resources to provide health navigation staffing at some of the new homeless shelters that have been created, so that those folks can get the health care that they need, but could also get on benefits if they're eligible for them. So those are just some examples of what's happening in Oregon.
Great. Thanks, Amanda. My two responses to this question is, number one, I think the long-term strategy for these kinds of housing-based service models is that we will have the data to prove that we are significantly bringing down Medicare and Medicaid spending. And I hope as a result of bringing down CMS spending that the federal budget can be looked at and scored by OMB as attributing some value to HUD and to rural development, and so I see that as a way to integrate and link our work and our methods, so that our work is actually feeding more funding to the production of more affordable housing and hopefully the reduction in homelessness. And second reaction to that is, if we really focus on true systems, if we increasingly start to think about the need for more supply, the need for reduced homelessness, and the need for true integration of health and housing, I think that those divides where sometimes we feel like the pro-production people in housing are eating away at the resources that we might otherwise have. I do think we will move into more alliance. And I see we have another question that has popped up here.
Nancy, can I add to that one real quick?
Please do, Howard.
Yeah, so I think some of the evidence and the data we've seen about, if you take people who have been homeless and have complex mental health and alcohol and drug and addiction needs, if you take people off the street, give them housing, give them wraparound services, health navigation, you see significant reductions in healthcare costs. One of the studies that was done in Portland by Core of Bud Clark Commons showed almost 50% reductions in healthcare costs within a pretty short time frame. So I think that argument is part of the discussion. Another set of issues to consider that's come into play in Oregon, you kind of have healthcare stakeholders broadly defined, could mean insurance payers, accountable care organizations, and hospital systems. And sometimes there's overlap in those categories. But the question of whether Medicaid funding or other funding sources from within those organizations can be used to support health navigation within publicly subsidized housing settings, should funding be used for actually bricks and mortar, particularly in rural or rural urban areas, purchase of properties that could be converted to either transitional or supportive housing for specific populations. And then the question of whether you use funding, Medicaid funding, or other funding sources for rent assistance. And that's a really active debate in Oregon. We've got 15 accountable care organizations around the state, and there's not consistency on the answers to those questions. But I think, as Amanda and Nancy have both indicated, there's a lot of intersection points and potential for collaboration, partnership, and alliance building around the question of affordable housing issues, homelessness, and the work that we're doing in health and housing integration.
Thanks, Howard. Well said. So we have a question. I think this one is going to go to Abby. What types of mechanisms were in place to track deliverables for SASH?
Sure. So types of mechanisms in place to track deliverables. So add to this if I'm misinterpreting it, because I'm going to think about it one way. But specifically, when we had deliverables, they were sort of quarterly reports to different funding agencies, specifically the state, about where we were in terms of health outcomes. And the mechanisms in place to track were more so, we have a database, then we have the identified measures that matter, that were agreed upon, that we were going to be reporting. And we, have that quarterly reporting requirement that we generated the information out of the database. The thing that we're noticing now is that while we're able to meet deliverables, we can do so much more. We're just not, we're meeting sort of that minimum requirement, but with a souped up database and a little bit more focus on our outcomes and our measurements. Not only could we report sort of the required health outcomes, but we could really focus on a whole bunch and do a lot more. So I think that might answer your question, from one narrow perspective, but I'm happy to elaborate more as needed.
Thanks, Abby. One more question from the audience, and then we wanted to spend a couple minutes at the end to talk a little bit about how funders specifically have supported our projects in concrete ways, and thoughts about, if you in the listening audience are wondering, how can you get involved? How can you support this work in your region? We have some ideas for you. So last question that came in, for the Oregon project, any sense of the percentage or level of individuals with mental illness who are part of the affordable housing services? And as a follow-up, any special considerations about working with this population?
That's a great question. So, and Amanda, you might want to jump in based on the evaluation data as well. But the first thing I'd say about the Housing with Services project is we've got 1,400 people. The initial needs assessment data and then the follow-up the 3-year evaluation is showing that we've gotten the specific numbers I don't have in front of me, but roughly 40% of the people that were surveyed initially, and I think those numbers were validated in the second round, are showing are self-reporting or through utilization data are showing really high percentages of mental health needs, and those range from serious and persistent mental illness, diagnosable Medicaid reimbursable conditions, to depression, anxiety, isolation, and so forth. One of the interesting things that came up in the 3-year evaluation is really high correlations between people that are experiencing some degree of mental illness and food insecurity. So that's going to kind of guide us in some refinement of the project. Of the 1,400 people in our 11 buildings, we have over 800 people engaged in the project. So for you managed care folks out there, you know, I consider that it's over a 50% penetration rate, and a very, as I say, a significant number of people are either identifying or showing through utilization data they have mental illness. Now, the one thing to answer the last part of the question is that we'd like to get to a higher level of community of resident engagement, and the people that we've had the hardest time getting to are the people that are in that broader behavioral health category and have alcohol and drug addiction issues. They're the ones that are the most resistant to contact by health navigators and our culturally specific outreach specialists, and we're in the middle of coming up with some more refined strategies through either community mental health workers or peer mental health educators to get to those individuals, because they can be high utilizer, high cost individuals. Lastly, what I would say is that we've got, and this will vary state to state, for people to we have mental health LCSW staff on the ground in the buildings, and for people to be able to get Medicaid reimbursement for mental health services, they have to formally enroll in Medicaid services, sign a release of information, and we've had huge challenges in getting people to do that. So our mental health staff are on the ground in the buildings, connecting with people, preventing evictions, doing community engagement activities, and having an impact on services utilization, but we're not able to get reimbursement for the services that are being provided. So the positions aren't quite sustainable yet. So that's a little bit overly long explanation, but that's.
Thanks, Howard. I mean, this is obviously a huge topic, and we can spend a long time on what I think is the most important topic, which is mental health among our resident populations. I would, for the last 10 minutes or so, like to take this opportunity to talk about funders and the critical importance of foundations, and want to talk a minute about how important foundations were to SASH in its early days. We were very fortunate to have a local foundation, the Vermont Health Foundation, that took a huge risk. They are led by an incredibly smart board of directors who are local opinion leaders in the state, and they took the risk of supporting the planning investment in this project, well before there was any proof in the pudding. And they also insisted that I go to the legislature and get a match appropriation to their contribution, which was so helpful to me because that was a lever for the legislature. We also had MacArthur Foundation fund us in the very early planning work, where we argued this is affordable housing preservation work. If affordable senior housing communities, turn out to essentially be nursing homes without care, without services, that will absolutely affect the financial stability of not only the housing itself, but the nonprofit organizations that own them. And so MacArthur agreed with that logic, that this was all part of the preservation picture, and supported our early work. And last, I would just say, we had banks, foundation support, United Way support, and we had enterprise community partner support for our model, which was greatly appreciated. Thank you, Amanda.
You're welcome.
And let me turn it to Howard and Amanda then. Could you share with the audience what were the roles for foundations as well as other partners that I know brought some very important resources to your work?
Amanda, go ahead and I'll fill in after you're done.
Okay. I'm going to speak both as a funder and as someone who receives funds. So first of all, Enterprise Community Partners provides capacity building support to nonprofits who own and build affordable housing. And so through this process of the study was all part of a learning collaborative. And so Enterprise was able to support a number of pilot projects that linked health and housing, including Howard's project, Housing with Services, with grant support. So, we were able to help provide some early capacity building funds for some of those early projects. Another example of a project we funded is a project where a nonprofit housing owner had a lot of senior housing projects, and they wanted to build a relationship with a nursing school to have nursing students come on site a couple times a month to provide services, but also to be able to track the outcomes of those services provided. And so that's just another example. And then as somebody who receives funding, we were very lucky early on to receive funding from Meyer Memorial Trust, who's a really fantastic forward-thinking foundation in Oregon. And they funded us to staff the Learning Collaborative, which brought these 9 housing organizations and healthcare providers together to start to really change the discussion. And then they also helped to fund the course study that I was talking about earlier. So I think funders can be really, philanthropic funders can really help to be that early in driver that's going to result in systems change eventually. So I'll stop there.
And I'll add a couple things to that. In full disclosure, as a former funder, I was the Vice President of Community Investment at United Way in the region. I will say that it's much more fun to give money away than it is to chase it. But we have 2 different categories of funding. I mean, I think the work that the Enterprise Learning Collaborative did positioned some of the larger regional funders, Meyer in particular, in setting health and housing funding priorities and supporting projects like Housing with Services, which we got a grant from, and the Learning Collaborative got as well. But so our funding is really in 2 categories: private foundations, but we've also been very successful at bringing money in from healthcare stakeholders. for some of the reasons I outlined in my presentation. Oregon, the largest Medicaid funder, both has hard cash in the form of the equity contribution and in kind through assigned staff and resources to the project. We've also got the smaller of the two accountable care organizations who has funded us to do culturally specific services, and they funded a full-time position that's been assigned to the project. And they've got a strong interest in getting data and doing evaluation on successful services for seniors and people with disabilities. We've also gotten in-kind support from the larger of the two accountable care organizations. They're doing data reporting and analysis for us. No funding yet from them. Providence Health Systems has assigned staff to the project, and the case that we're trying to make here is that if we're reducing costs and improving health outcomes based on the numbers of enrolled members that are residents in our building, all the healthcare stakeholders should have either or both a financial contribution to the administrative cost of the project and assigned staff if their enrollment numbers warrant having at least partial FTE on the ground in the buildings. So that's what we have right now, and that's where we're headed with funding with respect to both community benefits and health plan investments from the insurance payers and the hospital systems.
Great. So Abby, I know that you're very excited about your bi-directional data, and I'm just wondering if you could spend a few seconds to break out if there's funding need chunks both for the national work or the state work at state level work. What would you want foundations to hear in terms of the opportunity to invest in that?
Yeah, thanks, Nancy. I think that the opportunity to invest in SASH is definitely there. We are at the point now where we have a great idea, a lot of great track record, and we have this great data set, but we haven't been able to maximize it as much as we want to. And what we're looking for is some investment in sort of a data core, which would be around a HIPAA compliant, secure data system full of standardized measures and measures that matter. And we have the standardized measures and know that they matter. We just really need that bi-direction HIPAA compliant system so that we can use that at a state level, but then also use it as a platform for others to join in, so everybody doesn't have to recreate the wheel. And so we're sort of starting with a lot of legwork and a lot of great success behind us, but really sort of looking for that kickoff point to get this sort of data and dissemination core established within SASH.
Great, that's huge, just a huge need, and my number one excitement is about a national platform for all these models to get onto so that we can have a very big data set that we are studying and showing very significant outcomes. Last, I just want to say we have lots of thoughts on specific ways that funders can get engaged in this work, but I would say, because we have 2 minutes left, if you're a funder and you want to get involved in this or just learn what's happening in your area, please feel free to contact me or Enterprise, or you have leading age affiliate organizations in almost all your states. Contact any of the 4 panelists. We're very happy to talk to you, and we are fairly aware of what's going on around the country, and talk to many organizations, I'm sure, in your area. So please don't hesitate to reach out and talk over specifics. And last, again, thank you to the co-sponsors of this webinar, to Kresge Foundation that has funded this Funders Forum for years, and especially to Howard and Abby and Amanda for your excellent presentations. And thank you, participants, for giving your time and attending. Have a great day.
Thank you all.
Thank you all.
Thank you, everyone.
Bye, guys.
Bye, guys. Yep. Signing off.